Hello, Chad.
Hello, how are you?
I'm doing all right. How are you?
I'm good. I'm trying to pretend like I'm not winded from running down the hall, but I am.
That friend I was telling you about did have an appointment with the ENT and not looking good.
Really?
Yeah.
As I say, from your description, that didn't sound good.
Hello, Renee. Hello, Chad. How are you?
Diego, I'm well. How are you?
I'm good. Can't complain.
Good.
You can, just nobody listens.
That's right. No one cares.
Wait, you listen to me all the time, Chad. What are you talking about?
I'll just pretend. I'm not really listening.
Oh, gotcha.
Come on.
I always see that little red telephone with a thing through when I'm talking to you, but it's okay.
That's just because I can't talk back.
There you go.
Multitude of chess pieces are filling in.
Diego to rook 5.
I really suck at chess. I'd lose immediately.
LJ.
See, the Peds leadership team like bounces on all at once. Look at that. You guys travel in packs.
I must have gotten out of the same meeting.
Synchronize your watches.
Were you talking about me?
No, not at all.
Oh, good. Okay.
Yes, of course I was. All right, it's 12:15. Still looks a little light, so we'll give by another minute or so. Can't imagine people are outside enjoying the lovely weather right now. So it's been like monsooning every 5 minutes where I'm at. So,
Sun's shining here.
oh really? Okay, well maybe I'm lying. I was going to build an ark earlier.
I drove down to Long Island this weekend to see my sister, and the convoys of utility trucks, for the weather they were expecting was just nuts. 20, 30 of them in a row, just chugging along down the Long Island Expressway.
I don't think it was that bad either. Like I think
It wasn't.
Yeah, I was about to say, it sounded like it was better than what they expected. So,
yeah,
which is good. I'm not arguing, but for some reason, people who are in entomology may have an explanation for this. Whenever it pours down rain here, there are 1,000 butterflies that suddenly flutter. We have this weird awning at the front of the hospital. So there's all these butterflies, and they just it's Strong Museum of Play, the butterfly aviary thing. I feel like I'm just living in that here. It's just every time it rains, there's all these butterflies that just come out of the woodwork. They're never here any other time, but they seek shelter under the awning, I guess, when the rain starts.
It makes me think of the Mad Magazine spoof of, and now I'm dating myself, spoof of Raiders of the Lost Ark, where Sala looks into the pit and goes, "Oh, a man must face his greatest fears. If it were filled with butterflies, I would go."
They're kind of freakish because some of them are as big as birds. You get this thing fluttering right out of the sudden. There's windows on this wall, so it's you can't tell all of a sudden if they're in your office, and I know they're not. You would think after a couple months I'd learn it's just the butterflies again, but no, I'm oh my god, I do this all day long just to humor myself.
I have so many practical jokes in my mind right now. You're lucky your office is not as close as it was.
I terrorize my poor assistant because anytime I go outside, I immediately jump up against her window, and she hates me for it, which makes me giggle. So it's kind of fun.
Yeah, that's why she hates you.
That's one of the reasons, I should just say. At least I can be honest about it, own it. That's okay.
That was hilarious, Renee.
Thank you.
All right, so it's 12:18. Why don't we go ahead and get started, even though we're a little bit late, but maybe folks are out enjoying vacation time, so that's good too. So welcome back. I hope everyone has been doing well. I feel like these are so infrequent that when I see everybody's names pop up again, I'm like, oh wow, I haven't seen you guys in forever, which is a good thing, hopefully. So several important things to cover that have come up as of late. First and foremost, I will say, as of yesterday, we got word that the U of R is decommissioning their regional command center, which on the whole, I think you can take that as a good thing, that things are in such a manageable position. We are at the nadir that we were last summer during the pandemic, which is great. The nadir is so low, it's hard to say would we have gotten here without all the vaccination efforts. I think with the Delta variant and now the Gamma variant, and everybody's got a variant now, probably I think it would be safe to assume that we would probably be in a worse position. And if you look at parts of the country that have worse vaccination status, it does appear that there are micro surges in those areas for certain. So good news is, at least in the local community, we are doing quite well. But that also means that some of the information that would be pumped out from the U of R that we would be sharing with you may not be coming in the same way or frequency that it was before. So I just communicate that out to everybody so that they're aware. But the useless information that we spout off will be the same. That's the good news. So there you go. So as far as where we are, I'll say nationally, 47 of the 50 states are seeing an increase over the last 1 to 2 weeks of their COVID incidents. Now, locally, we had areas in our Finger Lakes community that had gotten down to about a 0.3% incidence rate. Over the last week, we're now all over a 1% incidence rate. And across the United States, over the last 3 weeks, we have seen a doubling of incidents from what it was 3 weeks ago. So on the one hand, it's, oh my God. But on the other hand, we are at a very low level nationwide at this moment. So despite the press kind of catchy lines, it is still a relatively low pervasion of infection. Also, the Delta variant discussion, no doubt, Delta variant has become the predominant variant in the United States. It is the predominant variant in New York State. It is the predominant variant in Western New York now. So it is here, it is real. The data about what the significance of that is uncertain. And what I mean by that is if you look at the data, it is anywhere from 60 to 225% more contagious than the Alpha variant. So the Alpha variant was the UK variant that we kind of all feared before. However, there has only been one large-scale study at this moment that shows that there are worse outcomes, hospitalization, mortality, than there have been with the other variants that are in existence. So there is almost greater amount of data suggesting that the Delta variant may not be associated with any worse outcomes. But be that as it may, it is clear that it is more transmissible. But in communities where there is a higher percentage of folks vaccinated, it appears that increase in rate of incidence is not a significant effect. So much so that there was a great article in Scientific American, I think at the end of last week, maybe early last week, looking at kids specifically in the 2 to 11 age group. And there's been a lot of discussion of should kids be going to camp? What about summer sports? What about return to school in the fall? Especially as there's been a discussion of relaxing masking standards for those who have been vaccinated in schools, and what will that mean for younger kids who may or may not have access to the vaccine by that point? And the interesting point that they pointed out in this article was that if you look at communities where vaccination has been going strong, which really there's only about 5 or 6 states that are really lagging at this point. Most of them southern or Midwestern, southwest Midwestern states. But if you look outside of those in particular, the rate of infection amongst kids under the age of 12 really has not changed. It's actually been relatively flat up until this point. And if you look at mortality, they actually cited an interesting statistic, which I had not heard, from the UK, which was about 500,000 kids in the UK have been infected with coronavirus. Now, in more recent times, Delta variant has kind of been surging in the UK even before it was in the US. There has not been a sizable increase in the rate of infection amongst that group. And the mortality statistics for 2 to 11 years old, of that 500,000 kids that were infected, there were only 25 mortalities for that 2 to 11-year-old group. And 15 of those were in kids with pre-existing serious illness. So all that is a long way of saying, in this community and really across the country and the world, the vaccines still show very good efficacy against the Delta variant. Number two, we know that even in communities where there are large groups of unvaccinated folks, the more who get vaccinated, the ripple effect where it actually has a shepherding protection for those who are not vaccinated. And so we're seeing that even in children as well. But even when children potentially get exposed to areas where Delta variant is much more prevalent, it does not seem to be changing substantively the rate of hospitalization, certainly mortality, and maybe not even causing a significant blip in the rate of infection amongst that population. So I point out that to say that article came out, and then there was another article that I think was in the New York Times, Washington Post, which basically said, kids need camp. And I think they had even quoted someone who was a former CDC director who said, the data would be highly in favor, especially with kids, even kids unmasked outdoors who have not yet been vaccinated, that the rate of transmission does not seem to be significantly different, even with the Delta variant being predominant. So I bring that up just as kind of a reality check of where we stand. That is not to undermine the importance of the Delta variant. I would say it emphasizes the importance of vaccination in those where the vaccine is available. But it also shows that, I think for our community, and, I think the hospitals can attest to it, the rate of hospitalization for coronavirus is at an all-time low, which is good. And certainly the ICU contingent of coronavirus is almost minimal, if not non-existent in most of the hospitals. So, I think I'm not saying we should ignore it. I'm certainly not saying that I'm trying to poo-poo this Delta variant, but I do think that, there's a reality check of what the actual implication of that is for our community at the moment, which is good to just keep in mind. So with that, the next big point of discussion has been booster doses of vaccine. So many of you probably saw, I believe it was last week, that Pfizer had petitioned the FDA for extension of their emergency use authorization for a booster dose of their vaccine because they had begun to show signs of waning of immunity, even in immunocompetent individuals, about 6 to 9 months after completion of the vaccine series. Now, that has created a lot of controversy for several reasons. Number one, can you extend an emergency use authorization to a kind of second booster, if you will, or a second iteration of the same drug? Or does that drug have to get primary authorization before you can extend emergency use authorization to it? That's important because if the FDA were to extend the EUA to include a booster, it could be in as little as 6 weeks before a booster was approved. If they had to go through the same trial and evidence base, it would be months before a booster could be approved. So that's number one. Number two, the CDC initially came out, and they seem to have relaxed the language a little bit, and said there is still no evidence or prevailing evidence that a booster is necessary. That while the antibody titers may be diminished after 6 to 9 months, that may not be substantively different from other vaccinations that we see, and that there is no evidence that it actually is causing a decrease in the level of immunity, reduction of risk of infection. So because of that, the CDC initially seemed to be very forward in saying that maybe there was no need for booster doses at this point. And then obviously the third thing was, well, if Pfizer has a booster, what does that mean for Moderna? Does Moderna need a booster? Does J&J need a booster? Should they be getting a booster with a RNA vaccine? Yada, yada, yada. So at this moment, it's still a bit unclear. I think all of us were anticipating that there would likely be an annual booster, but whether that booster would need to be accelerated based on Pfizer's application and data is still a bit uncertain. Contributing to this, you guys probably also saw that the FDA has now put a specific warning on the J&J vaccine that it does seem to be associated with Guillain-Barré. Now that incidence is still pretty doggone low, but that is, with all the issues that J&J has had, we thought it was going to decrease the desire for it. Then people preferred the 1-dose shot. Then we had the thromboembolic complications. It got the kind of pause on availability. And it was just coming back to being a preferred agent in some circles. And now this kind of warning on it about Guillain-Barré. So it remains to be seen what that effect that will have on utilization of the J&J vaccine, especially because in some of the hesitant populations, that was the only one that they were willing to consider. But I think we will probably hear more maybe in the next couple of weeks about what the future of booster doses will look like as the FDA kind of wanders through and considers this application from Pfizer. So I pointed out, I don't have any inside information, obviously, but it is potential that we could see booster doses become a reality sooner. Whether folks would be as receptive to booster doses is an interesting consideration that I think we just don't fully know yet. But it doesn't seem that there's a convincing amount of science at this moment that the booster doses are absolutely necessary at this moment. So more to come on that, and certainly we'll keep you up to date. The next piece, which is a quick one, I just received it today. It was dated July 9th. I received it yesterday. Blue Cross Blue Shield has come out and said that they would be continuing their waiver of cost share for their beneficiaries through December 31st for telehealth services, and that they would continue to waive cost share for COVID-19 treatment through the end of September. Now, 2 points that I would point out that they raised. Number one, this is extending beyond the state of emergency, which they had said they would continue to cost share waive through the end of the state of emergency. So they have done that. But they did point out, which we ran into before, many of you will recall, that for self-funded groups that use Excellus as an administrator of their policy, this may not apply to them. It is a one-off decision for those self-funded groups as to whether they will continue to provide waiver of cost share. And many of them haven't, and some of them even who signed my paycheck. So that has been an ongoing discussion in many circles, but just to point out that I realized that that makes it a trickier conversation because you can't just tell all Excellus beneficiaries that they will have a waiver of cost share, because if they are a self-funded employer, then it's that employer that gets to make that decision. But that notice did come out, which at least is good for the vast majority of our patients. The final piece for me are the Osha regulations. And this has been a big topic of conversation over the last week. Several folks have reached out. I know many of you, some of you feel like you got this in the bag and seem very not concerned at all. And if so, high five to you. Some of you, this has become a huge consternation to you, which I completely understand. And I will say that same sentiment is pervasive in the hospital world. Even in the U of R affiliate system, we have people who are hair on fire, worried that we've got to build barriers and put people into bubbles. And we have people saying, I think we're good, as we've kind of covered this. So several points I would say. Number one, even though the deadline for meeting those regulations has already passed, although we do have, for erection of barriers and that kind of thing, we technically have to July 21st for that. It is fairly clear that nationwide, everyone is struggling with this particular piece, New York State for certain. To make it even more complicated, the New York State HERO Act came out at almost the exact same time. So the two get conflated very frequently until Haney's actually came out a week ago and corroborated that the HERO Act is a temporary measure and that the OSHA regulations supersede and would be inclusive of all elements of the HERO Act. So for now, we just have to focus our attention on the OSHA regulations. The OSHA regulations, for any of you who have read them, read a bit like stereo instructions. They are painful, they are detailed. There is a checklist that is a mile long that is just, if you just do these things, you'll be fine. But that checklist goes on for pages. And the OSHA administrator did record a 52-minute YouTube video to simplify, but in fact, he actually contradicted himself in that video, which made it even more complicated. So several pieces I would say. This does apply to all of us. There is some consideration that for private practices, that there may be some outs. So if you're screening at the door, if you have staff who are vaccinated, that there will be elements of this that will not apply to you, whereas hospitals and hospital-associated practices get lumped in and treated as one group almost in most of the regulations. The other thing I will say is, it was mentioned yesterday on a Haney's call, there have been 2 hospital-based systems that have had OSHA visits in the last week. And for both of them, the almost solitary focus was around N95 fit testing. And at one of those facilities, they actually made them go back and re-N95 test their entire staff because they were not convinced that it was up to snuff. Already questions have come up to those on this call that I've mentioned it to, of, hey, we're only using surgical masks and face shields. Does this mean we have to use N95s? For the COVID purposes, I would say that answer is no. However, the OSHA regulations were meant to not necessarily be a direct response to COVID, but more so a response to communicable infectious disease in general. So the next COVID, what happens for the Ebola protections, blah, blah, blah. It was meant to be more inclusive of that workplace exposure risk than a direct response to COVID. The other thing that's made it a bit complicated is if you were to follow it to the letter of the law, you could erect 6 to 8 foot barriers between every employee that doesn't have a mandatory 6 foot separation from public and or other employees. And that would get to be almost impossible. Not to mention the fact that if you go out and try to buy plexiglass today, it is not readily available to anyone who would want to do so. So there are 2 clauses that we are still seeking clarification on. And I say we, there are multiple people, certainly across the state, who are kind of banding together to do this. So more information literally flows by the day. The first clause is all of these things should be implemented where feasible. And that where feasible is important. So if it would obviously disrupt workflow, if there is not the physical plant space to allow barrier implementation or whatever, it is adequate, it seems, at least from early implication, to make sure that staff has been educated, that they have appropriate infection prevention training, and that you have adequate PPE supplies on hand. So I can tell you from some of our own clinical spaces, we have registration staff who literally sit elbow to elbow. And to erect a barrier would actually put them inside of a box that would actually be difficult because there's someone else sitting within 6 feet of them behind them. So there will be no way for them to get out in a fire because they're boxed in their bubble. So clearly that is under the not feasible category, where we would just have to say this workplace is not amenable to it. So there does seem to be some opportunity there. And where feasible could even be, hey, is it financially feasible to erect plexiglass barriers anywhere right now? No, it's not. It's hard to come by and it's expensive when you do come by. So still waiting for clarification on that. The other one, which is a bit more esoteric, but interesting, is where risk of transmission is high. So right now, I think you could make a very valiant argument that most of the healthcare population is vaccinated. Even in those who are unvaccinated, the entire community has a relatively low risk of transmission at this moment. So one probably could make the argument that the risk of transmission of any communicable disease at this moment is low in our community. And therefore, we do not need to take more than general universal precautions that we would if someone were coming to the office with symptoms of being sick. So I put that out there to say there's a lot of uncertainty. I think for the moment, we are protected by showing due diligence of going through the motion, making sure our guidelines are updated, making sure that we're educating staff if we haven't done that already, making sure that we have adequate PPE supplies on hand, and that we all have workflows, which I know you all do, of how we respond when a person comes in with respiratory illness or other potentially COVID-like symptoms that we would respond to. I do not get the sense, and I think OSHA folks have gotten enough backlash that I don't think they're going to be rushing out to do site visits for everybody for fear of what that would bring on if they tried. So I do think there's going to be a lot of clarification that comes literally almost by the day right now. But I would say, and I think this is filtered down within the U of R as well, I would not be going out and spending significant sums of money erecting barriers, changing workflows to try to dance to these OSHA regulations, because it's still not clear what the permanence of these are going to be and what the absolute requirements are going to be at this moment. So I wish I had better information for you at this moment. I know that Monroe County Medical Society is actually hosting an event to discuss this as well. And I think they're going to have some speakers. I didn't get a chance to look through their email this morning, but I did see it come out this morning. So there is going to be a lot more information that's going to be coming out. I think we'll be getting more guidance from the state literally by the day. So as that becomes available, we'll certainly share that with you. But I do think there's going to need to be some at least specified attention to these regulations and an effort at due diligence. But I don't think we need to go hog wild and making full-scale changes at this point, because I just don't think it's feasible, even if we wanted to, quite honestly. So I'd say that. I realize you'd like a little bit more substance. Folks have asked, does AHP have a policy or kind of a, here's the version of what you got to do? I don't, and truthfully, I would say my answer to that question has changed even in the last 7 days, almost on a every day or every other day basis. So if we were to try to construct something at this moment, it would probably be different by tomorrow. So once we get a little bit more of a assurance of what we think the answer is going to be, we will relay that on to you as quickly as possible. And I'm happy to answer any questions, but I wish I could say I'm an expert on this. I am not, but you now know everything that I know at this moment. And I think that's all I've got. So LJ, I know you had some insight into this as well, so you can either add on or bring in new topics if you wish.
I think you covered it really well. I think it was just, the main thing is just to let people know it does apply, unfortunately. I think a lot of people thought they were exempted. I think just being balanced in your approach. If anybody does need a template or resources, various practices have shared what they've done or what they've used. So we can certainly, just reach out by email and we can share that information if you need it. And actually, I don't have anything else at the moment today to cover. So just, and Renee, I don't know if you have anything.
Nope, nothing.
So I guess open for questions.
Yeah, we can open it up. And the chat room is empty, so feel free. All right. Everybody seems happy in their place in life. All right, so we will call it a day. We will certainly, like I said, there'll probably be a lot of information that'll be forthcoming on some of these topics in the coming days and weeks, both about boosters and about OSHA. So we will share anything that we learn that we think is of substance and value to help along the way. But otherwise, for now, we will leave you alone and reconnect at our next scheduled meeting. And we'll keep that for now. Obviously, if the world becomes a happier, calmer place and we don't need it, we remain open to canceling these at any point. But OSHA gave us enough to talk about today that we figured this is definitely worth keeping for the short term. So more to come. Thanks, everybody. Have a great one.
Bye.